Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us. Before we begin, I'd like to thank our sponsors, Studio Arts and Glass, and Genuine Appraisals and Liquidations. Today, Brad and I are broadcasting from our administrative offices, and our special guest is Dr. Michael Linz, hospitalist with Cleveland Clinic Mercy Hospital. Good morning, Dr. Linz, and welcome back to the show.
Good morning, Paul. Good morning, Brad. Thank you for inviting me.
All right. Hospital stays can be full of surprises. One might be the doctor who shows up in place of your personal physician. Hospitalism is the fastest growing medical specialty in the United States. Demand for this specialty was initially fueled by managed care efforts to bolster efficiency, cut costs, and improve care. Today, patients admitted to the hospital tend to be more severely ill. Hospital-based doctors can better attend to such patients and respond to their problems and navigate the hospital's increasingly complex systems. Today, we'll talk with Dr. Linz and learn what a hospitalist is and how during a time when a patient might feel vulnerable, they are there to manage our care and work with our personal physician. We'd like to remind our listeners that our program today will also be available on our podcast, and you can check the App Store with your favorite podcast app and look for Health Matters with the Medicine Center Pharmacies. Please subscribe.
Okay, Dr. Linz, I understand you've prepared a brief pop quiz for us as before. For Brad and me, we didn't study, but we'll give it a best shot.
Well, that is very true. I always like to bring an interesting brain teaser for you. So those who know me know that I'm very passionate about music, and it's only outweighed by my passion for medicine. So what I've done is combine the two, and I'm going to ask you to name, if possible, my top 10 favorite pop rock songs that feature a doctor as a theme in the song, or there's a mention of a doctor in the song.
Gosh.
So I'll give you some help. Half the songs have the word doctor in the title. Most of the songs, 7 or 8 of them, are from the 1970s. There's a few from the 1960s, so that should be helpful to you. And just a few from the 1980s. So these are my personal favorites. I will give you some help along the way as you need.
Well, I can remember something with a witch doctor.
There is the witch doctor, that is David Seville and the Chipmunks.
Yeah. Okay.
That very, very famous song. That was not in my top 10, but in my second top 10.
And I know there's Doobie Brothers, Dr. Doctor.
Dr. Doctor was in the second 10 as well, and I'm finally
man.
Again in July. So,
all right.
If you'd like me to go through them, just for interest of time, that'd be fine. So my number 1 song is "Doctor My Eyes," which is the Jackson Browne song.
Okay.
There is the Bachman-Turner Overdrive, "You Ain't Seen Nothing Yet," where he goes to the doctor and he finds the cure for his love. "Life in the Fast Lane" from the Eagles, Hotel California. "Bad Case of Loving You," Robert Palmer. "Put the Lime in the Coconut," Harry Nilsson. "Say, Doctor, is there nothing I can take to relieve this bellyache?" Classic, Dr. Robert from the Beatles, from the album Revolver. Dr. Wu from Steely Dan. Katie lied, I'm a big Steely Dan fan. Doctor from the Thompson Twins.
Okay.
A couple of up-tempo songs. Dr. Feelgood from Motley Crue.
Oh yeah, I should have had that one.
From Kiss. I'm sure people remember that. And my tie for 10th is a song from the Young Rascals and Felix Cavallari. Paul, do you know that one?
God, oh man, that's something. Let me ask you something. Do you collect long?
Good loving.
Okay. Do you collect long playing records or anything like that?
I am into vinyl. My brother and I listen to a lot of vinyl.
Well, maybe you should send me that list that you just put out there, because I have a massive collection of long playing records.
I will be happy to do so.
And I might be able to find some there for you. Okay.
Well, thanks for sharing.
You bet. You bet. Okay. So, Doctor, tell us about yourself and how you got involved in this specialty.
Well, I'm a native Cantonian, born and raised. Went to Oakwood and Glen Oak High School. Did my undergrad and grad school at the school formerly known as Neo-UCOM, now Neomed. Was in the BSMD program there. Did my residency here at Akron, in Akron, Canton at Mercy and Altman. Started in private practice in 1987. So for 25 years, I was in private practice, and then about 11 years ago, came into the hospital to work as the hospital medical staff liaison, become more involved and active in teaching of the residents and medical students, and did some administrative work. In 2016, I was asked to take over and to run a new hospitals program that was being brought in from a group called Sound Physicians, and I have been the medical director for inpatient medicine since that time. July 1st starts my 36th year in practice.
Wow. Okay. So what is the history behind this specialty? I mean, it hasn't always been there, I don't think, because I remember on occasion when I was in the hospital years ago, my regular physician called on me while I was in the hospital.
Right, and that was the traditional model. I think Brad had alluded to some of those changes and reasons. Truly, you're right. For many years when I was in private practice, I would make hospital rounds early in the morning at both Mercy and Altman, and would be in the office seeing patients all day, would sometimes run back at the lunch hour to see patients, and definitely then go back after office hours and see patients in the evening and discharge them. Obviously, over time, that becomes not a time and cost-effective method of doing things, especially as managed care came in. So hospitalist medicine, you're right, is a very young specialty. It was first noticed in around 1995 when the concept of a designated admitting physician came around. And we actually had a group of 10 of us that would admit other patients, other doctors' patients for them as they needed because of our interest in hospital medicine. And so it evolved kind of loosely and then became more formalized. In 1996, there was a landmark article in the New England Journal of Medicine, and the term hospitalist was coined at that time by Robert Wachter from the University of California, San Francisco, who I still go to his conference every year, every other year, because it's that outstanding. And then due to managed care predominantly, as Brad had alluded to, and its emphasis on efficiency, the judicious use of inpatient resources, and the need to respond quickly to changes in patients' conditions and to really be in the hospital, that's really where things took off. And so over the last 20 to 25 years, it has been the fastest growing specialty in the history of American medical history. And now there are over 60,000 physicians who are hospitalists.
Seems to me that that could be a hectic job, though, too, being a hospitalist. And
it has its challenges. It is a large commitment of time. There's a lot of information as we have gone through the process of developing a hospitalist medicine program in physician burnout, work-life balance, those type of things. So it definitely has its challenges, but it has its benefits as well.
Well, I can't imagine what it used to be like when you started in the hospital in the morning and patient visits all day and at lunchtime back and after the day back. I'm thinking, my God, by the time you got home at night, you'd be dead.
Pretty much. You were on call 24/7. I was in practice before cell phones, so I carried a lot of quarters.
Sure.
Oh dear. Wow.
Didn't leave the house on the weekends.
Holy smokes. Huh? Okay. So what are the work models for a hospice? How often do they work, and how long are their shifts, and et cetera, et cetera?
The traditional hospitalist works what's called a 7-on, 7-off schedule. So they work 7 days in a row and they have 7 days off. We use that model here at Cleveland Clinic Mercy. Our day starts on a Wednesday and goes through a Tuesday. And so our switchover day is midweek. And the reason we do that is so we have continuity of care over the weekend. So to be able to discharge patients over the weekend and to be effective that way. There also is more of a Monday through Friday model where it follows a traditional work week and then you alternate weekends. But the model that we use, the 7-on, 7-off, is pretty much the model that most people use. there's a lot of flexibility now being brought in, what they call flex models. People working swing shift, coming in at 10 or 12 and working overlap shifts, working on a part-time basis, 4, 6, 8 hours, being on call for what's called a jeopardy, where you make yourself on call to be available if you're needed in the morning, and if you're not needed, then you're free for the day. And if you're called in, you come in and work. For working families with children, especially working mothers, those folks that just want to work on an as-needed basis, that helps to accommodate those people out of the traditional model. So that's really being driven by the, despite having 60,000 hospitals, there aren't enough. And so we have these flex models to be able to accommodate people's lifestyles and their home and family.
Well, in the middle of this, you would have to meet with other physicians, correct? The actual physician of the patient, or is there just a lot of communication by the internet, data, that sort of thing?
Yeah, well, a lot of things are done electronically. We communicate through electronic health record. When a patient's admitted to the hospital, the primary care physician gets a notification the patient's been hospitalized. They get a copy of their admission history and physical. We may communicate to them periodically during the hospital stay. We obviously provide then a discharge summary and a phone call follow-up at discharge, especially those patients who need to be seen in a timely basis. Unfortunately, there are some patients that succumb to their illness. So those are important things that need to be communicated to the physician as well. We probably handle, there are very few physicians in primary care that still come to the hospital. At Mercy, there's probably about a dozen, 12 to 15. And otherwise, we pretty much take care of all of the primary care physicians' patients in the hospital.
Okay. Doctor, it's time for our first break. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. This morning, we are talking to Michael Linz, Dr. Michael Linz, hospitalist with Cleveland Clinic Mercy Hospital. Okay,
Doctor, can you give our listeners an idea of some of the type of the patients that you care for? And I'm thinking about, do hospitalists specialize between maybe, say, pediatric patients versus adult, or do you specialize within your hospitalist designation?
Well, that's a good question. Hospitalists specialize within their training as far as who they see and don't see. The majority of hospitalists are adult hospitalists, and they are trained in internal medicine. 80 to 90% of them. I'm internal medicine trained. We also have some family medicine physicians who have had inpatient training that also are part of our team, and then also individuals who do medicine peds. We have a separate hospitalist for pediatrics, and there's also a growing population of OB/GYN hospitalists as well. We also have an OB hospitalist program at Mercy as well. And so they're kind of separate entities. A lot of as far as who you care for and who you take care of, a wide variety of patient types and disease processes. It's kind of based on the size and locale of the hospital, what available specialties are at the hospital. If at our institution we have board certified intensivists and cardiologists. If you're working out in a rural facility, you may be wearing that hat as well, as far as heart doctor, intensive care doctor, et cetera. It also depends on the degree of training of the hospitalist and their program, what they can do as far as invasive lines, ventilator management. If you have ancillary personnel such as nurse practitioners and physician assistants. And so those are all interesting factors that enter in. The interesting thing that as far as hospitalism is, it's the first specialty that's named based on the location of where you practice medicine, not the age of the patient, disease, start, et cetera. So we're kind of identified by the moniker of where we work, which I think is interesting. the model is value driven, and that's basically what is the quality of care divided by the cost, and is it a cost effective entity for healthcare. Things are becoming much more complex. Payer models, disease processes. I promised I wouldn't discuss COVID, but COVID is an entity in itself, and it challenged the American hospital system and us along those lines, basically to the 11th degree, and really required us to have resiliency and to be able to adapt, which we did. And so we know the model works because it works under duress. We see patients in the ICU, CCU, surgical floors, rehabilitation, and we also co-manage with the specialists in those areas. So our program is pretty much universal throughout the hospital.
So are you, as a hospitalist, an independent contractor, or are you actually employed by Cleveland Clinic Mercy Medical Center?
Our specific group is an independent contractor, and we can chat about sound a little bit later if you'd like. So there are different models. Some hospitals groups are hospital owned and employed. Altman Hospital has an employed model that they use, which works well. It's not that one works better than the other. It's just the personal choice of the hospital. We are an independent contractor. There are also private groups, again, a loosely formed group of physicians that may be a hospital coverage group for another practice, maybe 4 or 5 gentlemen and ladies that do that. And then there are some other models that work as well. But the major model is either hospital owned or independent contract.
Interesting.
Well, you mentioned sound. That's my next question. So tell us about Sound Physicians and its history.
Sound is a really unique company. It was founded in 2001, not too long ago, in Tacoma, Washington. The name of the corporation is named after the Puget Sound, therefore Sound Physicians. Our founder and CEO and president is Dr. Rob Bessler. Rob is a native Ohioan, grew up in the Berea area. His father was a professor at Baldwin Wallace, and he trained at the Cleveland Clinic and at University Hospitals of Cleveland, was an ER doc by training, and in 2001 formed a hospital group with 9 docs and pitched it to one hospital in Tacoma. Was given the shot to develop their program, and now 20 plus years later, they employ over 3,000 physicians, 1,000 NPs and PAs. We have sites in 40 states, and we not only have hospital medicine, but we also have critical care medicine, ER medicine, anesthesia, and post-transitional care. And we have become one of the top 10 physician services groups in the country.
Interesting.
We've talked a little bit about this, but what are the advantages of a hospitalist model of care? I guess, I think the first time I ever experienced that was, I thought, where's my doctor? Yeah,
Right, and that is part of the disadvantage, which we'd be happy to talk about as well. The data shows in the medical literature that hospitalists, because of their training, their background, they're being driven by statistical data and looking at metrics and aligning ourselves with our hospital partner. We're able to be efficient in our care because we're here 24/7. We can reduce the cost of care, decrease length of stay, and despite that, still have very positive patient satisfaction scores and reduction in complications. We do the same thing and take care of the same process every day, so it's a very focused skill set. And from a physician standpoint, it probably is one of the few entities that still allow some degree of work-life balance. You work for a week and then you're off for a week, and so it's all or none when you're working, but when you're off, you're off. When you're on. And so that can be a very positive thing for young families and kids and those type of things.
So if you're a hospitalist and you are off, you're not on call,
Right.
you know.
You are off, similar to a shift that somebody in fire or police work would do. You work, or ER medicine. So you work 7 days straight and then you're off for 7 days.
Well, that's really a very interesting concept, because in my time as a pharmacist, I can remember some doctors that really spent a lot of time and a lot of weekends and a lot of nights and all sorts of things that, you know,
25 years I did that.
Yeah,
So
to handle patient issues, and I'm thinking it really is a nifty change.
But, and it allows then the primary care physician to basically stay in their office, do their office-based practice, be more time efficient, be able to see more patients that need to be seen, and it allows them to control their lifestyle as well, because they're not being called at night, they're not being called by the ER at 2 o'clock in the morning, those type of things. Unfortunately, the advantages also roll into the disadvantages, and I think you hit the nail on the head, Paul. You know, the difficult thing is the fragmentation and the disconnect. When you've been seeing your family doctor for 20 years, you come into the hospital and you know, John Smith walks in the door and say, "Hey, I'm John Smith, your hospitalist. I'm going to be taking care of you." Well, how do you take care of me? You don't know me. You don't have my medical records.
Gotcha.
You have met me before, and you know, Dr. John Smith may be on his last day of service, and so Dr. Jane Smith may be taking over tomorrow. So fragmentation, that's part of it. And the challenging thing is coordination of care, development of a trust relationship, getting to know the patient in 2 or 3 days, where your family physician has known you for 20 years. And that is the challenge. The challenge is really developing trust with the patient, developing communication, and not as a physician who's a hospitalist, take a shift work mentality. I'm just working for this amount of time, then I get to go home. You know, it has to do with ownership of the patient and really committing to the patient as if you were their family physician.
Interesting. Okay, bottom of the hour, time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. You're listening to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning, Brad and I are talking with Dr. Michael Linz, hospitalist with the Cleveland Clinic Mercy Hospital. We've got a lot more to cover this morning, so let's get back to the show. You know, I think we answered this question, Brad, about sound and hospitalists, so maybe you should go on.
Okay, that's cool. So Dr. Linz, we understand Mercy Hospital's president, Dr. Timothy Crone, is a hospitalist. Is this customary for Cleveland hospitals to have presidents who are physicians? And what's it like to have a physician for a hospital president?
Well, the answer to that is yes. The Cleveland Clinic is one of the few hospital systems where every one of their presidents or CEOs is a physician, and they are all expected to practice some degree of clinical medicine on the floors on a periodic basis. You know, for myself personally, having a physician as president of the hospital who is an internist and on top of that is a hospitalist is like a match made in heaven for me. You know, we talk the same language, we see the same things, we have the same thought processes, and communicate on the same level. Dr. Crone is on service about every 6 or 7 weeks, and the week that he's on service, he experiences the same things that we do every day. And so he sees firsthand the challenges that are there, not only for physicians, but for nursing and the ancillary personnel, as well as different challenges and areas that need to be improved or worked through. So I think it works very, very well. And it also kind of dovetails with how sound works as well. Sound is physician run, physician owned, physician led. And so the model is very similar. And so that works extremely well. And I'm just ecstatic that he's here and leading our institution.
Interesting.
What are some of the changes that have taken place over the last 16 months since Cleveland Clinic and Mercy Hospital have joined forces?
Well, I'll leave the biggest for last. There's definitely been upgrades in our physical plant and equipment, investment in infrastructure, standardization of protocols, credentialing, and departments that we're aligned with the other 12 hospitals in the Cleveland Clinic system in Ohio, which then provides efficiencies and cost effectiveness. We're really focusing on quality, patient experience, patient safety. We have now what's called a CDU, clinical document, clinical decision unit, which is like a fast track observation stay for people that maybe only need to come into the hospital overnight. We have just launched a telestroke program where we have direct access through robotic monitors with the Department of Neurology at the Cleveland Clinic main campus. So basically, it's like having the Cleveland Clinic neurologist at the bedside. We have really increased our transfer program, bringing in transfers from outlying hospitals, south of Canton into our system to provide them tertiary care. There's been improvement in nursing wages and benefits to bring that up in line with what's customary and appropriate in Northeastern Ohio. And the most significant thing that we're doing is basically putting in a whole new electronic health record or electronic medical record called EPIC. That is a huge undertaking and is the major thing that is going to bring us up to speed. This has been in the works since before the clinic came in officially in February of 2021, and our go live date is a week from tomorrow.
Wow. Lots of luck. No,
thank you. It's going to be challenging.
Okay, I'm sure. Sure.
So, what about some of the goals of the Mercy Hospital transition into the Cleveland Clinic facility? You just mentioned some of them. Are there other high points that you want to hit?
Well, I read a recent article that on branded healthcare, and the Cleveland Clinic Foundation is the most recognized healthcare brand in the country. And so, the goal is being part of the Cleveland Clinic system, which we are very fortunate to have that opportunity, is to have a very straightforward goal to provide the best care that we can, and to provide Stark County and the surrounding counties with the level of care that the clinic is noted for, and also to be the best place to work in healthcare. But on a separate note, the sisters have only been divested for a year, and they were here for almost 120 years, and so we don't want to lose sight of the importance of what the Sister of Charity St. Augustine had this hospital brought to Canton for, and that is to be compassionate and provide care for the elderly, the poor, the underserved, the underinsured, and the uninsured. And so the importance of mission and values that were instilled by the sisters still remains at this hospital, still is widely practiced. The clinic coming in did not change that at all, which I'm very happy with. And so we still have our faith-based mission and values that still is at the foundation of everything we do.
Well, that's good that Mercy's held on to its root mission based on what you're describing there. So I know that there was always concern in the community from what we heard in the pharmacy that, with Cleveland Clinic coming in, that it would kind of change the mission of Mercy Hospital, but it clearly hasn't based on what you're sharing.
That's correct. The sisters and the board did a lot of due diligence looking at many different healthcare systems before they were able to decide that the Cleveland Clinic was the right system at the right time. The clinic had experience with other faith-based institutions. They have Marymount Hospital in Cleveland, which is a Franciscan hospital. The sale of the hospital to the clinic had to go all the way to the Vatican. So if the Pope says it's okay, I guess it's okay. We still have our clergy in the hospital, our priests. They still provide mass, based on COVID regulations. They still continue to visit the sick. They provide communion, last rites, spiritual support. And so that atmosphere and culture that Mercy was known for when you walk in the door is still there. And it's not being suppressed by the clinic at all. And that is very refreshing.
I happened to be at the Cleveland Clinic in Cleveland 2 or 3 months ago, and I cannot get over the massive operation that it is, and how pleasant and how kind the people were on the staff up there. And it is just, this as well as I do. I mean, the place is enormous. And traffic here and traffic there, and how do you get there, where do you park, but everything moves along pretty well. So for as large a facility,
patient satisfaction and quality of care is at the forefront of the clinic's model, and their model has changed over the last number of years. They're much more patient-centric. They understand that each community and their regional hospitals has its own flavor and its own interaction with the community. So it's not a cookie cutter model. We're allowed to maintain our mission and values, integrate the things that are positive about the clinic, and the tremendous support that they've provided us with maintaining our previous identity.
So we talked about projects that we're doing here locally with Mercy. Anything additional that you should bring to the table?
A couple of things. The clinic is looking at the major service lines in cardiology, radiology, neurology, and really upgrading those departments, not only with equipment, but with personnel. Dr. Crone's goal over the next 2 to 3 years is to have an additional 40 physician specialists in various disciplines to be part of our hospital system here at Mercy. We have already had additions in cardiovascular surgery. We have a new head of open heart and cardiac surgery, Dr. Harley Corliss, who comes from another Cleveland Clinic facility. We've added new folks in cardiology, radiology, oncology. We're developing our trauma service, which is a level 2 trauma service, to a greater degree, bringing in some very nice young surgeons. And again, integrating with the other clinic hospitals, and really focusing on becoming a transfer center, kind of the southern hub of the clinic's model, to provide that type of care for the rural section between here and Columbus. But nothing surpasses Epic as far as what it's going to do for the efficiency of the hospital, the accuracy of what we do, and the speed and efficiency of what we do. It's going to really bring us into the next century, which we've needed for many, many years.
Does Epic link us with the other Cleveland Clinic institutions?
Yes. Epic is a very interesting company. I won't go into great detail, but they're a privately owned company that's in Verona, Wisconsin, of all places. Okay. And it's a privately held company. The owner is a woman. Her name is last name is Faulkner, Judith Faulkner, and she, in a very short period of time, has developed the largest and most well-recognized electronic health record and healthcare software company, maybe not only in the country but in the world. They employ 10,000 people, and they have 55% of the market, and have health records on 250 million Americans.
Gosh,
and they're in all the major systems in the country.
Wow, that's amazing.
Clinic, Cleveland Clinic, Johns Hopkins, etc. And we were very fortunate they were negotiating our buyout, that they promised us that we were next in line after Cleveland Clinic London, and indeed we were. So they came and been here for over a year, getting us ready to go, and the countdown begins. It's going to be very challenging. It's a very complicated system, but once we get to know it, it's going to be tremendous in what it does for us clinically, medically, financially, et cetera. And for an old dog like me, it's hard to learn new tricks. But I'm going to my next training class this afternoon.
Okay. Okay, Doctor, our final breaks here. You're listening to Health Matters with the Medicine Center Pharmacy. Okay, welcome back to Health Matters with the Medicine Center Pharmacy. This morning, we are talking with Dr. Michael Linz. So, Doctor, we talked about some projects from Cleveland Clinic Mercy. Is there anything else that's on the table that's coming along here?
Well, one of the important things for the clinic is not only its own physical entity and structure, but support of the community as well. One of the other things that was very important for the sisters when they negotiated the sale of the hospital was that the philanthropic arm of Mercy would maintain and persist in the community, and that's occurred. So the Sisters of Charity Foundation, which has been in existence for quite a long period of time, it's a multi-million-dollar charitable organization that I was on the board for a period of time. Really tremendous things that they do, is still completely intact. They provide multiple grants for various projects in the community. A lot of focus on early childhood education with their Early Childhood Resource Center, their Bethlehem project for early dental care, and providing grants to the community remains completely intact. The Mercy Service League is still vital and intact, and their fundraisers and efforts support women's cancer, and not just the cancer programs, but grassroots support for the women who are challenged, those that may not have the wherewithal. They have an arm that they fund that helps to pay for transportation, help to pay their rent. I mean, nuts and bolts type of things in the community. The Mercy Development Foundation Development Board also funds various hospital projects, and that money stays local, which I think is important. The other big projects are that Mercy has been collaborating with the city of Canton to help develop the Peel Coleman Center in the southeast end of Canton into a multi-use medical, dental, and patient education site. That is an ongoing process. Mercy was also the major sponsor for the Urban League's 100th anniversary celebration and provided the keynote speaker. They also are a supporter of the Hall of Fame Village project. And so they are maintaining their philanthropic arm and becoming more involved in the community as they get to know the local area. As a side note, I wanted to bring up something as well. From the standpoint of the quality standpoint, because this directly relates to my physician group and the excellent nursing and personnel that work here. There is a rating that's called the Leapfrog rating, or Leapfrog group. The Leapfrog group is a multidisciplinary think tank of various corporations in the country that they measure the safety data and provide a safety score for most of the hospitals in the country. In May of this year, we received an A from the Leapfrog group, which was very, very important for us. One, we were the only hospital in Stark County to receive an A. We're only one of 44 hospitals in the state. Only 1 out of 3 hospitals in the country get an A rating. And the key is that this rating took place during the time of the COVID pandemic. And so I think this is really a testament to the commitment and compassion and the caring of the individuals that work at Mercy Medical Center. And so I wanted to bring that as an aside, but something that I'm proud of as a physician at this institution.
Super. I think we did talk about this. The Cleveland Clinic transition, bring additional physicians to Mercy, or additional therapies aren't the right word. What am I?
Ancillary services.
So yes. Okay.
Right. So in addition to the specialty and subspecialty additions of physicians, continued growth of primary care, and so Mercy has facilities in various counties, Carroll County, Tuscarawas County. They're expanding their physician-based primary group in various parts of Stark County, trying to grow that and provide more access to care. The St. Paul Square has been a stalwart in the Northeast community area for quite a long time, and have these physician offices and outreach programs strategically placed throughout the community, especially in areas where there's a lack of primary care. But it's not all bricks and mortar. It's programs that can be transitioned to in the home, in the schools, those type of things. And so definitely an ongoing project through outreach and mission.
Since the building or the hospital itself is pretty well, it's pretty tight, the land and the availability of to expand areas around them. What's going on with that? Has there been any talk about that, or?
Nothing particular right now. That's been discussed on and off for years.
Yeah.
And there's always been the discussion about going up, basically building a new tower or revamping the tower. Not something that's currently on the table, but I'm sure will be looked at as the hospital continues to expand. We have been busier now than we have been in a number of years. And I think there are many reasons for that, but I do believe the clinic, by reputation and by results, as far as what we've been able to produce as far as quality and safety and patient experience, drives those numbers as well.
We've talked about how Cleveland Clinic acquisition has brought great things to the community and the hospital. And, can you just touch on one more time what you see for the future in Canton, Ohio with the Cleveland Clinic and Mercy Hospital joining up, and how you're excited, or what you're excited about to see what's coming?
I think without us partnering with a larger entity, and specific with the Cleveland Clinic, I think the ability for Mercy to remain as a standalone hospital would have been very challenging. So they provide us, the financial support, the infrastructure, the programs, the quality, and the patient care that is going to, first of all, maintain us for years to come. And their programs that are at the main campus and at the large regional hospitals will become integrated into what we do here as well. We are very fortunate in Canton, Ohio, to have two excellent institutions, Altman Hospital and the Cleveland Clinic Mercy Hospital. And I feel that both institutions will continue to maintain as the foundation of medical care here in Stark County. And we do some projects together. Our medical education projects that we do are in co-sponsorship with Altman. And my personal hope is that we can do some shared projects together and integrate systems to become more efficient, more cost-effective, more cost savings for patients, not replicate services that can be done at one institution or the other. and to really just have a solid community-based health system that pretty much can handle anything that walks in the door. And our use of the campuses up north are more for quaternary care, transplants, bariatric surgery, very complex open hearts and neurological surgical procedures, and that we can really provide 90+% of the care that our Cantonians require here locally, which I think would be beneficial in many ways, especially with gas at $5 a gallon.
Okay, Doctor. Thanks for coming by today. This is really great and very, very interesting what we heard. And Dr. Michael Linz, hospitalist with Cleveland Clinic Mercy Hospital. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to our sponsors, Genure, Tag Sales and Appraisals, and Studio Arts and Glass. Have a healthy week, and we'll see you right here again next Friday on News Talk 1480 WHBC.